Good afternoon and welcome to the American Heart Association's Southwest Affiliates webinar titled Stroke Essentials, EMS and Stroke. The American Heart Association is proud to offer a suite of quality improvement programs that can help you advance further and faster in your quest for ever better quality. For more information about these programs, visit www.heart.org/quality. Today's webinar is the fifth in a series of offerings focusing on the essentials of stroke care. We will be calling upon experts in our Texas primary and comprehensive stroke centers to share their knowledge with professionals who are new to stroke or professionals in smaller facilities where the staff handle time-critical diagnoses. We'll be meeting the fourth Tuesday of each month from 12 noon to 1 p.m. If you have a topic that you'd like to hear in this series, please let your local quality improvement director know. If you don't know your quality improvement director's name, we will be providing contact information at the end of today's webinar. Before we get started, I'd like to go over a few housekeeping items. All phones have been placed on mute in the back end to cut down on background noise. To ask any questions throughout our webinar, feel free to press *6 to unmute your lines or use the GoToMeeting question and answer section. Also, all slides and handouts for today's webinar will be sent to all attendees within 1 week of today's call. And also, we are doing an audio recording, so feel free to visit www.heart.org/SWA-quality to view the audio recording within 1 week of today's call. At this time, I would like to turn it over to Shanti Raj, the Director of Quality Systems Improvement, to introduce our speakers for today. Shanti?
Thank you, Larissa. It's my pleasure to introduce our panel of speakers today. Our panel is joining us from Plaza Medical Center of Fort Worth in Fort Worth, Texas, and from Bedford Fire Department in Bedford, Texas. First, I'll introduce the following three speakers that are all from Plaza Medical Center. Ms. Sharon Eberlein is the Neuroscience Program Director at Plaza Medical Center and has been a nurse for over 38 years. She received her RN from Tarrant County Junior College and her Bachelor's in Nursing and MBA at Texas Women's University. Ms. Eberlein was instrumental in advancing their hospital's level of stroke care by successfully obtaining the comprehensive stroke certification. Dr. Vellava Janardhan is the director of the Texas Stroke Institute. He completed his vascular and critical care neurology fellowship at Harvard Medical School and his interventional neuroradiology fellowship at Cornell and Columbia Universities. Dr. Janardhan's areas of expertise include interventional neuroradiology, neurocritical care, and the development and operations of brain attack networks both regionally and nationally, resulting in one of the largest regional brain attack networks in the country with over 120-plus hospitals in North Texas and Oklahoma. Dr. Alex Venizelos joined the Texas Stroke Institute in July 2013 to pursue a fellowship in endovascular surgical neuroradiology. He attended medical school at Wright State University's Bonshaw School of Medicine. He completed his medical internship at Metro Health Hospital in Cleveland, Ohio, and his neurology residency at Loyola Medical Center. Dr. Venizelos completed his first fellowship in neurology critical care at Rush University Medical Center. Our last two speakers are joining us from Bedford Fire Department. Deputy Chief Bobby Sewell is currently recognized as a leading advocate for stroke care in North Texas. He leads the North Texas area in the development and implementation of pre-hospital stroke care. Chief Sewell was instrumental in creating a pre-hospital neuroassessment tool based off the National Institute of Health Stroke Scale. This rapid field assessment tool allows the patient to bypass the ED and go straight to the CT scan. He also works closely with Dr. Yamada, EMS Medical Director, with the development and innovation of patient care quality improvement. Lastly, Dr. Roy Yamada is currently the EMS Medical Director of the Fire Departments for the cities of Bedford, Pantego, Hearst, Richland Hills, North Richland Hills, Allen, Midlothian, Grapevine, Euless, and Dallas-Fort Worth International Airport. He is instrumental in changing the pre-hospital care for STEMI and stroke patients in Texas. Dr. Yamada received his medical degree and surgical internship from the University of Hawaii in Honolulu, with a rotating internship and orthopedic surgery residency completed at John Peter Smith Hospital in Fort Worth. Thank you to our panel of 5 speakers for joining us today. I will now turn it over to Dr. Venizelos to begin the presentation.
Good afternoon, Dr. Venizelos here. Thank you so much for that kind introduction. We're going to start off with a little bit of an overview of what we're going to talk about today, hopefully touching on the importance and acute management of ischemic stroke and hemorrhagic stroke, and how to improve the collaboration with EMS and hospital systems. Next slide, please. We're going to start off with a little bit of a stroke background, discuss who we are, where is Plaza, where's Bedford, discuss the link of emergency medical services and stroke care, talk about a little bit of what we need to know, some acute treatment options, immediate hospital care, and future directions in EMS. Next slide, please. I did want to start with a case study about a patient who came in recently to the hospital. Only 33 years old. He was with his wife that morning, and she got up to make breakfast. He was talking to her normally, and when she came back, she noticed that he was slurring his speech and not moving his left side. She very quickly notified EMS via 911. They were there within 10 minutes of her noticing the symptoms, and they accurately assessed and determined that the patient possibly was having an ischemic stroke. They notified the emergency department that they were coming, and they were prepped. The pharmacy was ready, the CT scanner was ready, and the hospital received the patient, and he presented there within 1 hour of his stroke symptoms. On arrival, his NIH stroke scale was 16. He had a left hemiparesis, he had a neglect, he had slurred speech, and he was able to receive IV TPA after a negative CT head within 30 minutes of his presentation. Unfortunately, this young gentleman didn't have any improvement in his examination following the intravenous TPA, and he was brought to the angiography suite for potential thrombectomy. Clearly, you see a picture here of an angiographic image. The patient is facing us, and you see the filling of the right internal cerebral artery and bifurcating there at the ACA and the MCA, and there's an abrupt cutoff of the right middle cerebral artery there, representing an acute thrombus. Next slide, please. We'll get back to him in a little bit of background about stroke. It's the third most common cause of death in the United States. It's the leading cause of adult disability. So it's a very common disease, a very common disorder, and 87% of those strokes are ischemic. Even though it is a leading cause of death and disability in the United States, intravenous TPA, which is the medication we use to treat acute ischemic stroke, is only administered in about 1.8 to 2.1% of ischemic strokes, and this was based on a study in 2008, and this is really why we're here today. It's a combination of community outreach, EMS collaboration, acute hospital treatment and careful consideration that is going to help identify these patients so that we can administer medicines more quickly. And why is it important? Why is it important to try to reperfuse the brain as soon as possible? And I find this to be a very striking statistic. It's 1.9 million neurons are lost every minute that an ischemic stroke is left untreated. So it leads us to the common phrase that time is brain, and not 30 minutes, not an hour. Every minute, 1.9, almost 2 million neurons are lost of when a brain is ischemic. So that's a pretty impressive statistic. Next slide, please. In a survey in 2005, so even though it's important to quickly recognize stroke, to try to administer TPA, to try to reperfuse that brain, a survey in 2005 found that 93% of patients in the community were able to recognize stroke-specific symptoms. So they were able to say that their loved one may be having a stroke. However, only 38% of those same people that were interviewed knew that they should call 911, that there was an important and an urgent matter at hand that could be treated acutely. And to underscore the importance of recognition and rapid triage and transport of these patients, there was a study in 2004 published in Lancet that patients who arrive in the emergency room within 3 hours have less disability than those at 3 months compared to those who received delayed care. So not only are we able to treat patients that arrive there earlier, they have improved outcomes than those who have delayed care beyond that 3 to 4.5 hour time window. Next slide, please. I did want to touch on some different types of stroke. We tend to lump them all together. While ischemic is the most important type, it's important to recognize that there are two major types of issues when we talk about stroke. Obviously, ischemic is due to a lack of blood flow to a certain area of the brain. There are several types that we use to consider what type of therapy we can potentially offer. One is lacunar, which tends to be a small vessel issue due to lipohyalinosis of small blood vessels in patients with diabetes, hypertension, high cholesterol. And those tend to be smaller subcortical types of strokes. And then there are large vessels that can be involved. These strokes are usually caused by a clot or a plaque breaking off from someplace, traveling either from the carotids or from the heart, or maybe even from the leg and traveling through the heart to different areas of the brain. Those are in certain vascular distributions. So if the middle cerebral artery is providing blood flow to a certain part of the brain, you'll see that part of the brain affected. And the reason I bring that up, it seems fairly straightforward, but hemorrhagic strokes don't obey those same rules. They cross vascular distributions. And then you can have the combination, to make things more confusing, that you can have ischemic stroke that then bleeds into the area of ischemia, and that's called an ischemic stroke with hemorrhagic conversion. So it's very important that we know the terminology and know the types of stroke we're talking about, because there are different treatment strategies for the different types of stroke. In the hemorrhagic stroke category, there's three major ones that I identified here, and neurology is always going to be based on the area of the problem. So if the problem is in the brain tissue itself, we call that an intracerebral or a parenchymal hemorrhagic stroke. You can have primary bleeding into the ventricles, or you can have a subarachnoid hemorrhage. And subarachnoid hemorrhages are typically caused by either trauma or ruptured aneurysms, and it's the identification of which areas of the brain and whether the stroke is ischemic or hemorrhagic that's going to guide our treatment in acute stroke care. So that was a little bit of background in ischemic and hemorrhagic stroke.
Thank you, Dr. Venizelos. Next slide, please. This is Sharon Eberline, and I'm going to give you a little background on Plaza Medical Center. We are a magnet hospital, and we sit in the heart of downtown Fort Worth, located in what we call the Hospital District. We are a Level 1 designated Certified Comprehensive Stroke Center by the state of Texas. We also have a GME program. We are a large neuroscience service line in which we see not only the stroke population, we have spine, brain tumor, epilepsy, and other patients. Our neurosciences also include our Texas Stroke Institute, which is a stroke initiative by our HCA North Texas Division. And thus you'll see the sticker on all the slides. Texas Stroke Institute, we call them TSI, which is made up of our endovascular stroke neurologists. We also have an active GME program with fellowships in certain specialties. Next slide, please. A little bit about our partners from Bedford Fire Department. They are located in what we call the Mid-Cities area in the DFW area. The EMS from Bedford respond to over 4,300 incidents per year, and that's trauma and medical emergencies. They have strict requirements for all their paramedics, and Dr. Yamada will discuss that further in a few more slides to come. Besides completing a successful 6-month field training program, they have to pass their comprehensive protocol and skills testing. They are required to attend monthly training classes. They also receive additional certifications, including NIH stroke scale, ACLS, and PHTL. And they are staffed with their firefighters and paramedics, their medical intensive care units. Next slide, please. Just a little bit about our location for those that do not know where Fort Worth, Texas is, and this is where we sit. We are located in the northeastern part of the state. Next slide, please. And in Tarrant County. And you will note where Bedford, the city of Bedford and Bedford Fire and EMS sit in relationship to Plaza Medical Center. Let's talk about the first step. What do we do when we partner with EMS? What we did, we arranged meetings with our local EMS agencies, which included our Bedford partners, and then we discussed our current practices and decided how we needed to improve. We looked at things that were outliers. What took us so long to get from 911 to the hospital, and then what took so long from the ER doors into giving the TPA. So we worked on those goals. What we found was if we did field blood draws, we did a rapid transport and a neural assessment in the field, that decreased our door-to-needle time. And once you do this and you monitor your processes, and we did this for quite some time and cut off quite a bit of time from door-to-needle by just having the field blood draws. Then our EMS agencies got together again, and we talked about doing EKG transmissions. Well, you do it for STEMI, so let's do it for stroke. It's nothing new. And we always have the equipment available. So we started transmitting our EKGs for strokes as well. So once you figure out and monitor your processes, you need to celebrate your successes, and you do those with your EMS agencies. You provide timely feedback. You give them the information immediately and make sure that the EMS paramedics that brought the patient actually receive that information. And then you share your data. You have to get buy-in from EMS and your ED staff first, but then once you do and you share the data, then the collaboration has already started, then you celebrate all your successes for greater patient outcomes. Next slide, please. To emphasize the importance of EMS collaboration, here are some of the meetings that we have with our EMS agencies. We attend these in order to work on our processes and improve patient care. I really cannot imagine working without EMS as our partners to prevent any negative outcomes for stroke care. Together, we have decreased the door-to-needle time. We initiated the field blood draws, and we've been doing that for 3 years now successfully. We are transmitting our EKGs for strokes, and we have field stroke activations. All of that has decreased our door-to-needle times, not only for Plaza Medical Center, but for our sister hospitals as well. Next slide, please. So in essence, you have to act fast. Time is brain. There is an article regarding paramedics using the FAST acronym in the field and assessing their patients. And this article talks about doing that, and what they concluded was that the recognition of neurological deficits by paramedics in the field, which is early recognition, using a FAST acronym, agreed with the physical assessment done by the physician in the ED. This study also indicated that just assessing the arm weakness has the greatest usefulness for pre-hospital EMS triage and paramedic-based neuroprotective trials. So in essence, what this is saying is that, figure out what EMS neurological assessment you're going to do, whether it's FAST, the LA score, Cincinnati, etc., or rapid NIH, and get it done in the field. And then when you radio in the NIH scale or your Cincinnati to alert the ED staff on the potential problems the patient's going to have. And I'm going to let Dr. Yamada and Chief Phil discuss further about the EMS.
Thank you, Sharon. If we don't get to any strong point from EMS today, one thing at the end of the day is I just want to continue to impress the point of strokes being handled as an emergency. It's something that we've dealt with for a long time, and with the treatments that we have today, and the things that at our disposal, we still see hospitals and hospital staff still not bringing strokes to the same emergent level as we do with our STEMI patients or trauma patients. But the fact is, they're just as much an emergency. In fact, time can be more critical for these patients as we're losing brain cells to try to protect their quality of life. Next slide, please. And this is getting to the point that we was talking about as far as making it a true emergency. And I don't know exactly how to motivate our staff and our hospital personnel to do that, but as I'm going to talk about that point a little bit more as we go further. Next slide, please. Actions of EMS impact outcomes, and we've worked on this for quite some time. Me, Dr. Yamada, and our system in all of his cities. We were very successful early on with the STEMI program, activating the cath lab from the field, been able to get the patients there diagnosed, transmit the 12 lead, bypass the ER, and go straight to the cath lab. And our criteria that we go on for STEMI patients is 911 to balloon of 60 minutes. Looking at our stroke patients and the times when we started breaking them down with our hospital partners to try to identify all the things that EMS could do to help improve those door-to-needle times. And in doing that, then our goal for EMS would be to, our part of the 60 minutes that we want to look at was 911 to have our patients ready to go, the alert called in within 30 minutes of dispatch. And we've been able to achieve that. And then the goal of the hospital then would be from door to needle of 30 minutes for their processes. So we broke down from the time 911 was called until we was ready to administer TPA, and all of the people involved in that, and all the processes involved in that. And that's when we started looking at ways to improve times. We started looking at things that EMS could do in the field that wouldn't have to be duplicated at the hospital. And we were surprised with some of the things that we've seen. So, we taught our personnel that was trained in a certified, identifying stroke. And then, the sudden onset of last known that we can get for our patient histories, of course, is very important to get that to the hospital. And then we perform a rapid NIH. We'll talk about that in a little bit more detail here in a minute. But our paramedics are trained, and they assess it, and then they then give that information to the hospital, and the hospital can correlate that into a value that they can use as they're assessing the patient. And then we want to be sure that that information will activate the code stroke to the hospital. They'll activate the stroke team and be waiting for EMS upon our arrival. We'll manage blood pressure. We're going to conduct field draws. In our study, when we was breaking down times, we learned that we curtailed 15 minutes, or say 15 minutes of door-to-needle time by EMS drawing the blood in the field. We did a handoff with the lab techs as soon as we hit the door, and there's the emergent part. When we call for a code stroke, the hospital team has to be waiting. EMS arrives, we do the handoff of the blood, it goes straight to the lab. Those values are received quickly to get back to the doctors, and on an average, we say 15 minutes. And, in brain cells, that's critical time. We also administer 2 IVs. We transmit the EKG. The 12 lead in the hospital, if we got that prior to us arrival. All these things save those critical minutes that we're looking at. Next slide, please. So, our goals. EMS was 911 to the ED door, 30 minutes. Assess patient using our rapid NIH score. Alert the stroke team at the hospital. Secure the 2 large bore IVs. Transmit the EKG. Do the blood draws. Control our blood pressure. And rapidly transport to the appropriate hospital. Dr. Martin, would you like to talk a little bit about the EMS responsibility?
Yes. I think first the medical director has to train that the hospital that they're transporting to, the CEO is involved and it's because it's top down. The CEO, the neurologist, the interventionist, the emergency department nurses and techs are all on the same page, because we may spend a lot of time trying to devise a plan, and if there's no support from the hospital or the hospital healthcare service, the plans fall apart and the paramedics are disenchanted and won't bring patients to the hospital. So we must have appropriate training for our EMS, not only on the FACE or Cincinnati, but the Rapid NI score, which means something. It's a score that we can give to the hospital and follow that score in the hospital for outcomes. And the protocols need to be addressed for strokes, especially with blood pressure. And the medical director needs to be involved in stroke and have a strong partnership with the hospitals. And it's all in passion of saving the one life that no one else can save. In a group of people, can you tell which patients have had a MI and survived? No, not unless you look at their chest. Can you tell which patients have had a stroke and not responded? Yes, and I'll show you somebody without a job that can't support his family. So our passion is stroke. I myself was a victim of a stroke. Dr. Chinardin is here, and he was my doctor, fortunately, and Sharon Plaza was my hospital. I came home and I talked to my wife on the phone. She was out of town. She said, "Roy, I think you're having a stroke." And I didn't realize that I was weaker on my left side and my speech was just a little garbled. I thought it was my Hawaiian accent. And so she called Bobby Sewell, and he came over and brought me to Plaza. And immediately Dr. Janardin did I was ushered to have a CT scan, and Dr. Janardin came in and didn't leave any stones unturned. And I think back, and if I had a deeper stroke and I wanted to go to sleep at home, and I said to my wife, "No, I'm just tired." In fact, she got our son from Chattanooga to call me. He's a neuroradiologist. And he said to his mother, "No, I think Dad's just tired. He's okay. His intellect is okay." And Chief Sewell brought me to the hospital, and luckily he did, because I would be without a job right now and couldn't do what we're doing. So I feel that for a hospital, we don't take our patients to the closest facility, always to the most appropriate. And we have developed strong partnerships with Plaza Hospital in our neuro care for our patients with stroke. A team approach is very important. Next slide.
Thank you, Dr. Mata. Time is critical, and we hear that. But do we actually pick up every second that we can in a process? And that's when, I encourage everybody to partner with your EMS. Look at 911 all the way through the process until needle, and find out where you can shave off a minute. I know everybody's resources are different geographically, EMS, hospitals, but I think anybody can improve their programs. If you'll break it down in a timetable, in every minute that can be picked up, I challenge and know everybody can save sometimes. And we know that every minute is those brain cells that we're losing. So, here's the things that, we EMS, from our standpoint, quick assessments, that patient history is very important. transport to the appropriate facility. We might have to transport a little further, but it's critical to get the patient to the appropriate facility that can actually treat that patient. Because if we go to the improper facility, then we have to transfer them to somewhere else. We're losing those critical minutes. So it'd be easier to get them to the right facility from the get-go. So anyhow, next slide, please.
So we've been talking a lot about patient transportation and triage. There are a couple things I wanted to address to rapidly assess treatment options for patients from the field. Some helpful questions, because when the patients present to the hospital, usually they're the first ones there. Maybe family isn't available, maybe family's on the way. So some important questions to determine the ability to treat ischemic stroke or hemorrhagic stroke that I tend to ask when patients are in the emergency room or to EMS who transported the patient is to determine the last time the patient was known normal or the time of onset of stroke. So when you examine a patient, you want to know who saw the stroke symptoms occur. How did they know it was a stroke? Not, I think my family members are having a stroke, but why did you think that? What did you see? It's important to get an idea of what their pre-morbid functional status was. So what is normal for them? And sometimes it's helpful to say what were they doing, because it's going to be different if they were sitting in a bed or in their wheelchair because that's what they always did, and they were working out in the yard or they were driving a car. It's always helpful to have a list of their home medications, again, because families are rushing to get to the hospital or patients are transported via EMS, and to determine what treatment options there are for ischemic stroke and what we should do in patients who have a hemorrhagic stroke. It's very important for us to know what medications they were on at home. It gives us insight to their past medical history. It gives us insight to what medications we can and cannot use. And then it's helpful to know if there's a recent or remote history of bleeding. And if you really touch on these 3 points and really hammer home, what they were doing, how it occurred, and get a glimpse into their past medical history with this limited information, we can make some very important treatment decisions when they hit the door. Next slide, please.
Okay, we talked about the EMS field blood draws, and then the research that we did when we was partnered with the Plaza Hospital. And here's a picture of the blood draw kits. And the hospital furnishes those for EMS. So when we use those in the field, when we bring a patient, they hand us a new kit for the medics. But that means the hospital is basically using their tubes. They're comfortable with it. We set that up with the labs when we started the process. And but we do draw the blood, and then we label it to the time and the patient, and we do the blood and give it off to the lab people. And through our research, on an average, it saves us 15 minutes door-to-needle time once at the ER, which those are critical minutes that we was able to pick up by just doing this one skill in pre-hospital setting. Next slide, please. And then we secured 2 large bore IVs, requested by the hospital. One of them, we're going to use those. We're going to actually draw the blood, and that can be a slate saline lock for future use where we draw blood, but we have the access available. And then we'll have a TKO IV, depending on, we're treating the blood pressure. And we treat our patients by protocol, a MAP about 120 is what we want on our stroke patients. And so we'll use that for that. Sharon, would you like to expand on those?
Absolutely. Thank you, Bobby. And that second IV can also be used for contrast, for IV contrast, because we routinely do the CTs, but then we may do a CTA, and then we have our brain attack MRA studies as well. So we do need that second IV, large bore, preferred above the wrist.
Okay, next slide, please. Okay, and we talking about the rapid NIH, so that is performed. Paramedics in the field are filling that out, and there's a copy of that that's left with the hospital and can be part of medical records. But we do 2 different assessments, one initial assessment of the patient and another one at the ED. with the ED staff. Then we can see what changes from our initial exam. Is the ED, could be 15 minutes or whatever the time lapse had been to kind of see if the patient's improving. Are they stable? Are they getting worse? It's great information. We're currently doing an IRB on this rapid NIH, and soon I hope to be released so we can share this with a lot of people. But it's a great tool that we're using, and we've been testing, and we've had great success with it. Next slide, please. Here's a quick copy. Everybody can read that. It's kind of small on the slide. But will we assess? Dr. Mata, would you like to comment on that?
Yes. We added the posterior fossa infarct on the left-hand side, the bottom left hand. And essentially, I've had several of my patients, my employees from the cities, have a dizziness and ataxia. And it wasn't recognized by the hospital that we transported the patient to, that the patient was having an infarct in the cerebellum. And the only way that you can diagnose it is with MRI, not CT. CT is blind to that. And so in one case was my police officer from Allen. He ran into the house to help the paramedics perform CPR, and he dropped in the front yard, dizzy and sweaty and just feeling horrible. We transported him to the hospital, and in the middle of the night, I asked for an MRI, and they wouldn't do it. So the next day, I traveled up to the hospital, and the hospitalist said, okay, he laughed at me. He said the CT was negative. Well, I went into the ICU, and the patient looked horrible, and his family was there. And they performed the MRI and found the cerebellar infarct. It was from his vertebral basal artery, of course. And with steroids and everything, he responded to that, and now he's back on duty as a motorcycle police officer in the city of Allen. So we added that to improve the tool, and it's good for the paramedics to know that if they have a score of 8 and the patient was discharged with a score of 2, that they've maybe made a difference. It's almost a visual tool for them, rather than the Cincinnati score or the LA score or the FAST score. This is a objective tool that they can use for them. So this also excites the paramedics. And you're welcome to use any part of this. Next slide.
As we call in the code stroke, you've got to have the partnerships with the hospital because it needs to mean something. When the paramedics calls your hospital and call it in a code stroke, something needs to happen, something needs to change. And if it doesn't, then we're missing out because we need to prepare for that patient like we do a STEMI, like we do a trauma patient coming in. We're very blessed in the DFW area. We have a comprehensive center here in Plaza we work with. We have a primary stroke center also that's closer to our city. So that's also part of TSI. It's North Hills Hospital. So if we have a sudden onset, and our goal obviously is that door to needle to be able to get the TP on board. The paramedic on the NIH, it did give the criteria that we go. So patients that have an NIH of 8 or greater with some other criteria, anyhow, they will go to the comprehensive. That's probably going to be more. Dr. Genard can discuss that. But anyhow, and if it's a sudden onset, it's lower than 8, they're a candidate for TPA, then we would go to the primary first where they can get TPA on board really fast. If it's going to be another criteria that's going to require maybe the next level of care or the criteria, then we will transport straight to the comprehensive center. So that's unique for us that we have those choices. I know a lot of people don't have those choices. But as we get education, through the paramedics to get the patient to the appropriate hospital based on their patient assessment. Next slide, please. And patient follow-up. When you partner with your hospitals, patient follow-ups are absolutely wonderful to have, and very, very important to have. Because to introduce and add more responsibility in our EMS crews, they have to understand what they're doing, why they're doing it. But they've got to see the results of their work, and those follow-ups with the hospitals does tell us where we are. It lets us know, are we making improvements with the improvements that we've made in our system? Are we seeing those in our actual patient outcomes? Those all do transpire back into maintaining and into morale of the paramedics. Because paramedics in the field, initially, they've got to make the right decision, get to the right hospital, and if we're not doing those things, or let's say the paramedics don't think no matter what they do, it's not going to make any difference at the hospital or with the patient outcome, then, we're losing out. So all of that does go back to maintaining the morale of the paramedics. We've got to look at our times combined, 911, when we're dispatched, until we have the to needle. Our goal here is 60 minutes. That might be impractical for some other areas, but we've been able to achieve that here. 30 minutes is EMS, 30 minutes at hospital. And we've done that successfully, and it does greatly improve our outcomes of our patients. And training, improve the process. In other words, we keep training, we keep learning. When we know better, we do better. We keep looking at our processes. When we meet with the hospitals, we look at our times, and we're always looking for other ways to tweak the system. And believe me, when you think you've got it right, you run through it for about 6 months, you're going to find there's other holes in the systems. Or we're improved here, we fell off here. So that process has to be constantly reviewed to try to stay up at the levels we want. Next slide, please. EMS. Our job, EMS, to educate. We have to be the ones that carry the message, because we are out with our citizens. We see our public every day. We're part of their lives. So our responsibility is education. Education is we will educate our personnel. Our medical director, we have to educate our medical director, both him educating us in medical. We educate our medical director or keep our medical opposed to what's going on in the community as far as educating our citizens. Our partners, hospital partners, there's education on both sides, to us and from us back to them, as we identify our everybody in the chain for improved stroke care. So that's our personnel, our medical director, our hospital partners, our management of our organizations must be behind what we're doing and understand what we're doing, because we're going to have to ask them for some extra tools or some extra time or whatever, or extra training, whatever those situations are. Our management has to be involved and supportive to improve our programs for better stroke care. We have to educate our public and our citizens. What are we doing and why are we doing the things that we're doing? Which then leads into our local government and our elected officials need to understand what we're doing with stroke care. Because if we bypass, if we go to the appropriate hospital, and let's say my closer hospital is a primary, but this patient required the comprehensive center. So we go to the comprehensive, then there's going to be calls to the mayor's office. Well, why did your ambulance not stop at the close hospital and go to the far hospital? They need to understand why we're doing what we're doing to try to impact patient care, and then share our results with all these people. Share your results with your citizens, your elected officials. Be able to tell them what improvements our program has made in our stroke patients and quality of life issues. Next slide.
So we have just a couple more slides, and we're running a little short on time, so I'll try to finish things off quickly for you. We have talked about pre-hospital care, community outreach, rapid identification, triage, and transport of these patients. And then they arrive to the hospital, and we wanted to talk briefly about some acute treatment options. Next slide, please. Once they arrive to the hospital, and this brings us to our therapeutic time windows, which we keep revisiting when it comes to ischemic stroke therapy. Really within that 4.5 time window is when we're able to give TPA to appropriate and eligible patients. Based on their response to the administration of TPA, based on some advanced imaging, based on their stroke severity, their age, and Chief Sewell did mention something else that should be on this slide, and that's their pre-stroke functional status. We can make some decisions at comprehensive centers to go on and do some sort of endovascular therapy to try to help that patient at that point. Next slide, please.
Thank you, Dr. Venizelos. I just want to run through quickly how we receive a patient here at Plaza Medical Center. Now, remember, our process starts with our EMS folks. We receive the EMS stroke field activation. We immediately activate the code stroke pager system. Upon arrival, our EMS folks take our patient straight to CT. The ED physician, nurse, and codes team meets the patient and the EMS in the CT control room. The patient is placed on the table, as you can see in the picture, and this was a stroke patient that we received here this past week. We have our lab that just accepted the blood from the paramedic. We have our physician at the bedside. He's talking to the patient and getting a quick overview, NIH. And then we have the nurse getting report, listening to what the physician is saying and listening to what EMS is also saying. Next slide, please. The patient's vital signs were also obtained quickly in CT. We have pre-registration at the bedside so we can get that patient registered. As we know, we can't do anything until we get the patient into the system. So we do it all in CT and in the CT control room. Once the physician completes his NIH, he notifies our Texas Stroke Institute, our TSI physicians. TSI reviews the scans, and then they recommend the course of care. Next slide, please. There are thrombolytic indications for stroke, and of course we look at symptom onset. Dr. Venizelos briefly touched on that within 4.5 hours. We look at the CT without contrast. We look for any bleeding, any other pathology other than acute ischemic stroke, and then age is a criteria. And then we make the decision with TSI and the ED physician to administer TPA. Next slide, please. Our TPA at Plaza is mixed by the ED nurse at the bedside. We have a clot box that we take with us to CT, and we start there. Once the patient is examined, we go right to the treatment room where the RN is mixing the TPA. The patient is also further assessed once the TPA is initiated. Then what we have discovered is that historically we were doing CT-CPAs back-to-back. And after doing mock code strokes, working with our EMS partners, we felt that we would get a CT first, initiate TPA, and then go back for the CTA. And this decreased our door-to-needle time. We get a CTA or a brain attack MR to see what's going on with the patient, and then we monitor for neurological deterioration. And what that means is the nurse will monitor for headaches, nausea, vomiting, worsening stroke symptoms, and a decreased length of LOS. Also, when you give TPA, you need to monitor for angioedema. And this is if it's an allergic reaction, tongue or mouth swelling, respiratory distress, rash, and then you act immediately. You stop your TPA with both neurological deterioration and angioedema. Next slide, please.
And the treatment of stroke doesn't stop with intravenous TPA. It doesn't stop with endovascular therapy. There are several important points, hemodynamic considerations and electrolyte considerations when we treat these patients. It's important to try to keep the brain perfused. If there is a large vessel occlusion, sometimes there's some collateral circulation to that area that is helping a patient hang on to part of their exam. And these are what this idea and some advanced imaging is what's going to help guide us to proceed with different treatment options. Next slide, please. Sugar, glucose is a very important parameter to monitor in addition to temperature. patients are supposed to be euglycemic, so you don't want their glucose in the 300, 400 range, but you also don't want to over-treat elevated blood glucose. So it's very important to have protocols in place in the emergency room to control blood sugar in a very controlled manner in addition to other hemodynamic parameters. Next slide. And once the patient is in the hospital, whether or not they get TPA, as we're controlling their hemodynamic parameters and the laboratory values, we use advanced imaging to decide whether or not we may be able to help the patient with different types of endovascular therapy. I have several of them up here on this slide. There are suction devices where we go in there with basically a vacuum and we try to pull that clot out from inside the blood vessel. There's also a stent, several stent retriever devices on the market. New ones are coming out every day, where you deploy a mesh stent into the artery. You allow for the clot to integrate with that stent, and then you try to pull that clot out with or without suction device help. There's a corkscrew device. Obviously, we talked about intravenous intraarterial TPA. And then the bottom set of pictures here are some treatments that we use for hemorrhagic stroke, because we've been focusing on ischemic stroke, but all types of stroke can be treated. All types of stroke need rapid triage and treatment. So we are able to deploy devices to stop aneurysms from bleeding, to stop arteriovenous malformations from bleeding, and to help patients who have vasospasm or other problems due to their subarachnoid hemorrhage. Next slide, please. And I wanted to finish off here, at least with the organized part of the talk, to bring us back to the patient we started off with. 33-year-old man again, a father of young, 3 children, did receive TPA. Unfortunately, didn't get any better after the TPA. You see the before angiogram we saw on the bottom. His NIH stroke scale at that time was a 16. We did a stent retriever device, and we were able to pull the clot out of the middle cerebral artery. The following day, his NIH stroke scale went from a 16 to a 4. He only had a mild left hemiparesis the next day. Interesting timing. Just last week, he came back to see us, and his NIH stroke scale is now a 0. He's back at work. He brought his wife and 3 young children to see us, and this is something that was very close to us as a team, seeing how the whole effort, community outreach, EMS collaboration, emergency room treatment, and acute hospital care has really affected this person's life, and will continue to fight to elevate the stroke care in this region. That's it. Next slide, please. And next slide.
I think the future of stroke care is exciting. We're working with Samsung on ultrasound, and Mr. Park from Korea, the top CEO, came in, and my health sciences nurse asked him, "So, Mr. Park, what's next?" And he said, "Portable CT scans, mobile CT scans." I'm also in touch with Dr. Hochler from Germany. He's with UC San Diego, and he's using Dopplers, identifying clots in the middle cerebral, and he's using a solution that bubbles with the Doppler and dissolves the clots. So it's exciting where we're going, but we'll do it again with partnerships with you, with the neurological community. And it's exciting, though, all the benefits the patients can have.
And final thought before we have questions, I wanted to thank everyone for taking the time to listen to this webinar. I'd like to thank all the speakers for being here, for the invaluable work that they're doing for the community here and sharing best practices across the country. A summary take-home message over here is twofold. As we're developing better and better therapies with stent retrievers and newer generation thrombectomy devices that can push the time window of treatment beyond, At the same time, it's important to optimize the whole chain of survival in stroke care. And I hope this webinar has given some insightful information regarding how 911 to needle or 911 to revascularization times can be improved, similar to our colleagues in interventional cardiology with door-to-balloon time. So in addition to having new therapies, it's important to optimize the chain of survival, and that's the summary of this webinar. So thank you all for taking the time. We're open to questions.
Thank you all so very much for this presentation. And Dr. Yamada, thank you for sharing your personal stroke survivor story. I appreciate that too. At this time, anyone, if you have questions, please press *6 to unmute your lines. Did anyone have anything from the phone? We did have a question come in via GoToMeeting, so I'll go ahead and start with that one. Getting family with valuable information into the ER is always a challenge. How do you overcome this?
That is a challenge. I mentioned earlier patients are usually the first ones to arrive to the hospital via EMS, and families are rushing out the door, driving their car, concerned, and it's not a good time to try to contact them on their cell phones that they may or may not even have at that moment. So we try to bridge that gap with EMS. Sometimes they're the ones that have that valuable information and are able at the patient's home to grab a medication list, to give us concrete information about what their last known normal or what their time of onset was. I think that when we're trying to administer TPA as quickly as possible, having that information by the time they hit the door is extremely important. And if we can encourage that transfer of information with the patient, I think that's the safest and most rapid way to do that. I don't know if anybody else has any thoughts.
The only other thing I would add is in those situations where stroke patients come to a smaller rural hospital, get stabilized there, and then are going to be transferred to a comprehensive center in an urban metroplex, it's vital for the physicians talking to the ED physician over there to collect the contact information of the family prior to the patient being air-flighted to the Comprehensive Stroke Center. It facilitates the treatment team in the Comprehensive Stroke Center to utilize that travel time to do the consent or to provide more information to family en route. So in those situations where it's a direct EMS activation directly to a comprehensive stroke center, partnering with your EMS colleagues and your champions in the field is vital to the success of this effort.
Absolutely, and I think the Rapid NIH score sheet has all those questions on there, last known normal, and their family members, and so that's also a trigger for them to question the family.
Great.
Absolutely, and as for nursing in the emergency department, we become very creative in trying to obtain that information. Our EMS partners are wonderful. They may bring us a cell phone, they may bring us a prescription bottle, empty or not, and then we can backtrack. We can call the cell phone number if it's family, friend, and get some history. If we know the physician that prescribed the medication, we call that office as oftentimes as we've done. We've even called pharmacies where the medication was dispensed to get the information. But you have to be creative sometimes in retrieving information.
Great. We had one more question come in via the online tool. What are your thoughts regarding the 3 negative endovascular trials published in 2013 comparing endovascular to IV TPA effectiveness?
I'll take a crack at that question. The way I would answer that is the 3 trials that happened were in the TPA eligible population. So these were patients who could be randomized to just TPA therapy or TPA plus endovascular therapy or just endovascular therapy compared to TPA in the TPA treatment window. As a rule, across the country, only 4% of the patients across the United States with stroke are actually being treated with TPA, which means 96% of patients are not eligible or not getting TPA appropriately. These 3 trials do not cover that 96% population. Those trials have been done, and there's enough valuable information to show that in the TPA ineligible population or in patients who do not receive TPA, endovascular therapies with mechanical thrombectomy is vital, comprehensive stroke centers are crucial, and partnerships with EMS is important. In the TPA eligible population, which is a much smaller percentage of patients who actually show up in the emergency rooms, it's important to realize that most of these trials were shown to have equivalence to TPA, and they were only, the majority of them looked at older generation endovascular devices, more so endovascular infusion of medications. The present generation of devices have moved away from using more medications inside the brain with risks of bleeding and are more of a mechanical approach to open up the blood clot. Future studies will help define that better. So in conclusion, majority of the patients are not treated with TPA or come outside the time window for TPA in the ERs across the country on a national average, and none of these 3 trials cover that 96% of the population for which there is growing evidence of benefit of endovascular therapies.
Great, thank you. And I know we're running over time, but we had one more question. Would y'all mind taking it as a panel?
No, go ahead.
Okay. When transporting patients from a primary stroke center to a comprehensive stroke center with continued hypertension, do you have any protocols for EMS to treat them? Since most crews don't carry Cardin, I don't know if I'm pronouncing it, Cardin, on the rigs?
Yes. We were just discussing this item. And in our ambulance, we carry labetalol, and we try to keep the MAP at about 120 and in transport, but we're always in discussion with the sending and receiving physicians as to optimal blood pressure. We don't want the blood pressure to go too low and obviously not too high. So we use labetalol in our EMS. Cardin is quite expensive, and I don't think we can keep it on our shelves. But it's important to keep the blood pressure within a range. And I use the MAPS, mean arterial pressure.
Great. We had one more, and I think this will be our last question for our webinar, but thank everyone for staying on the line. Do you support the currently published AHA guidelines about interactions within a stroke system of care with the recommendation to only bypass if going less than 15 to 20 minutes for EMS? Does that...
I think Dr. Yamada and Chief Sewell can answer this, but this comes to the core question that was discussed during the webinar, that the closest facility is not always the most appropriate facility, and it's more important to go to the most appropriate facility rather than the closest facility. Dr. Yamada, any thoughts?
Absolutely. The same with the cardiac centers. We bypass the hospital without interventional cardiologists and go to the facility with interventional to protect brain or cardiac muscle.
And the other advantage is that by having pre-hospital stroke severity scales that are done by the ambulance paramedics, it may help serve like an EKG for brain attacks and help triage people appropriately to a level 1 comprehensive stroke center, similar to a PCI-capable cardiac hospital, compared to a level 2 primary stroke center, similar to a non-PCI-capable fibrinolytic hospital in the cardiac sphere. So more research needs to be done on pre-hospital stroke severity scales and triaging, and that may be the focus of appropriately triaging to the appropriate facility. We're doing a lot of that over here, but more work needs to be done, and it's an important question.
I would want to follow up on that, not knowing the root of the question, but but it does depend on, I guess, the patient condition, EMS capability, because we want to preserve the patient's life. We do want to go to a appropriate facility. If the EMS doesn't have the ALS capabilities of supporting that patient, then maybe it would be a closer hospital for you. But each program and medical director is going to have to decide that. But we stand by going to the appropriate hospital and not the closest hospital in our EMS.
Great. Well, thank you all so very much. Appreciate you taking the time to do this webinar for us. I believe everyone found it very informative. And thank everyone who attended. Again, we'll be sending out the slides and handouts and everything within a week of this call. Thank you all, and look forward for more information about our next webinar coming up. Thank you again to our panel. We really appreciate it.
Thank you.
Thank you.
Thank you.
Bye-bye.